The same straight leg raise. Up to this point, folks, there has not been one test, not one, that's been unilateral. It's either been like a foraminal compression test, which is midline, an East test, which was simultaneous, and the majority of other tests were bilateral in nature. Okay? When we start getting into the lumbars, you're going to start to get some of these tests that are unilateral in nature. And the reason is that if you do it on the opposite side, they name it a different test. It's the same test, but on the opposite side. So, the first one we're going to do is a Lasag straight leg raise, and it is done on the affected side only. So therefore, this is a unilateral test. If we do it on the other side, it's going to be called a well leg raise. That's not in my book, but it's the same test as a straight leg raise, but you need to know it anyway. We've been testing this in the clinic. So let's do a Lasag straight leg raise. Place your superior hand above the knee, inferior hand under the calcaneus, and all we're going to do is get the leg up to 90 degrees. That's the entire test. Now, as the leg is going up, 0 to 30 degrees, if the patient starts to develop sciatic-like symptoms. From 0 to 30, we're thinking that there's an SI lesion. The next joint up from the SI is going to be lumbosacral. So from 30 to 60 degrees, we're thinking lumbosacral. When we get above 60, the hamstrings are working on this side to do what to the innominate? Which way is the innominate going to rotate?
Posterior.
Very good. What does that do to the lordosis?
Decrease.
Very good. So with that, we're going to get changes in the lumbar spine. And if it turns out that the lumbars become involved, as you go above 60 to 90, it's going to come into play. Now, Dr. Demianov, that's the next test, came around and said that I have a lot of patients that when I do a Lasag straight leg raise, they have discomfort from 0 to 15 degrees, but yet they don't have an SI joint lesion. What he found was that the majority of these patients had erector spinae spasm. So, the best way to do a Lasag straight leg raise would be to say, I'm going to go from 0 to 90. From 0 to 15 degrees, if the patient has symptoms, Dr. Demianov said it's erector spinae. 15 to 30, sacroiliac. From 30 to 60, lumbosacral. Above 60, what would it be? Lumbar. We did that on the affected leg. If I go over to the well leg, this is called the well leg raise. It's not in your book, you just write it down. It's a piece of paper. Now watch. I'm going to do the same thing. I'm going to bring the leg up to 90 degrees. This is the well leg. If the patient has symptoms, where do you think the symptoms are going to be felt? The sick leg. This is classic for discal lesions. Again, 30 to 60, 60, 30, 0 to 30, 30, 60, 60 to 90. But guess what? Discal involvement. Because look what happens, folks. When I start to raise the leg up, what am I doing to the hamstrings? Tight hamstrings does what to the innominate on this side? Posterior. As it goes posterior, what's it going to do to the lumbar lordosis? Decrease it. As the lordosis decreases, which way is the disc going to want to go? Posterior. Where's the most common site for a disc herniation? Posterior lateral. Can you see the mechanics behind it? Now, let's go back to the sick leg. The test that we want to do, following a Lasag straight leg raise, let's say I bring it up to about 45 degrees, and it hurts. If I bring it down 5 degrees, does it still hurt? Say no. Good. If I take my hand like this, place it on the calcaneus, forearm on the sole of the foot, and I dorsiflex the entire foot, stretching the sciatic by doing that. That's called a regard. Now, Let's say you don't want to dorsiflex the entire foot. If I bring the leg up to the point of pain, well, let's say straight leg raise, drop it 5 degrees, and just dorsiflex the big toe. That's called Sicars. Now, this patient has one hot leg. They don't even want to let you lift the leg up. You get on the big toe, and you push the big toe. He's got his shoes on, obviously, it would be off. Push on the big toe. And the patient has an increase in symptoms. Again, going down the leg, that happens to be called turns. Now let's go to the well leg. You do the well leg. I bring it up, it hurts. Which leg's going to hurt? Sick leg. If I bring it down 5 degrees, dorsiflex the entire foot. That's referred to as a fascia stance. Next, if I bring the patient's leg up to the point of discomfort, and I try to go further, what's the patient going to do with his knee? No. Why? Takes the pressure off the hamstring, right? Now, if I sit down, and by the way, that bending in the knee that he does on his own, it's called a buckling sign. Now, I'm sitting. I take the buckled leg, I place it on my shoulder like this, take my thumbs, get in the popliteal fossa, and I push. This is called bowstring sign. Common for Monet. Raise the affected leg up back 20 to 30 degrees. Internally rotate the leg and adduct across the body. This stretches the piriformis. So let's do the Lysaid rebound. You're going to bring the patients up to the point of pain. Now, in the olden days, we would stick a ruler down on the table and let the leg drop. You don't tell the patient you're going to drop it. As the leg starts to drop, what does the patient instinctively try to do? Stop it from dropping. When they do that, they tighten the abdominals, increase intra-abdominal pressure, intrathecal pressure, and if there's a distal lesion, this will increase sciatic radiculopathy. Now, the same differential. Bring the leg up to point of pain. What's the patient going to do with their knee if you try to go further? Bend it. As they bend it, continue to bend it. Now, what am I taking out of play here? If the patient has sciatic radiculopathy, or the patient had tight hamstrings, when I bring the leg up like this, and the patient buckles, what's taken out of play? Hamstring. So, even like this, there may be a little bit of reduction in sciatic, but the hamstring is really being taken out completely. So you're differentiating between hamstring and sciatic radiculopathy. That is passive, patient, Petrin slip. They all three have P's. Okay? So what you're going to do is this. If you remember, we worked on the patient's left side. So we're going to start first with the patient's right side. Place your hand above the knee, extend the leg. Now what I want you to do here is what? What's the number of degrees of his torso to his leg right now? Now, if he was not able to do this, laying down, so this would be the well leg raise. Remember we just did that before? This is the unaffected leg. If he had a well leg raise that caused pain on this leg, with him sitting, since this is a distal test, discs don't like people that sit, and I'm doing this, shouldn't he be symptom expressive as well? If I was able to do this without any symptoms coming on, what am I thinking? You bet. So we start with the unaffected leg. Then we do the affected leg. Okay? If I'm able to get this leg up all the way, something's not kosher. Then you take your forearms, place it on top like this, You go underneath and raise both legs together. Now, don't move. Keep your hands tucked right where they were. It's exactly what I wanted. Thank you very much. Now, if he truly has discomfort, in order to decrease the angle in his torso, what's the patient going to do? He's going to lean back. That is the flip portion and touch of the flip. Now, in order to prevent his torso from going off the table, what do you do with his hands? One hand here, and his butt here. Tripod sign. Tripod sign is what we're looking for when he leans back in order to prevent the 90-degree angle from happening. Vectorus, we're going to do this. One of the students came up with this, and it helps them. The phrase to remember with vectoru is 1-2 vectoru. Okay, if that helps you out. So, vectoru, the patient is seated. Have the patient actively extend the unaffected leg. Down. Extend the affected leg. Down. Both legs together. Boom. He's doing that actively, so he knows when the pain's coming. If I'm telling him to get the legs all the way up, what's he going to do with his torso? Lean back and grab with his hands, and that's a tripod sign. Okay. The last one in the seated posture is called diarrhea sciatic tension test. It is exactly like the bowstring. So if I take the affected leg, and let's do this one as the affected leg, and I start to bring it up. If I don't want him leaning back, what's he going to do with his knee? Buckle it. So he buckles it, I take it, I can place it on my shoulder, get in like this, and squeeze. That is diarrhea sciatic tension test, and it's very similar to doing a bowstring. We've done it as seated posture. Advancement test, otherwise known as the anterior innominate test. Have the patient take the affected leg, place it forward. Now ask the patient to bend forward and touch their toe. Stop. What's the number of degrees between the angle between the torso and the leg? More than 90. Should he be able to do this if he couldn't do it laying down or seated? Patients don't understand this. But can you see where all this stuff has to be similar in design pain-wise? Yes? If not, what are we going to suspect? Malingering. Now, here's something else that you can do. It's called, you do it on the affected side and the unaffected. If the patient had pain when they bent forward, it could be coming from the lumbars, it could be coming from the pelvis. So we're going to do a test called the belt test. So what we're going to do is the patient bent forward, it hurts. Take your hip, put it into their sacrum, hold on to the ASIS, ask the patient to bend forward again. Do that. What am I preventing from moving? The pelvis. If the pain is gone now, where was it coming from? Pelvis. If they still have the same pain, it's not pelvis, it's lumbar pain. That's called the belt test. So when everybody stand, I'd like you to take 10 steps on your heel. Before I feel your in heels. We should have you up here to do that. Now, 10 steps on your heels. What do you think they call this test? Heel walk test. Now, take 10 steps on your toes. What do you think they call that? Toe walk test. Now, here's how you're just going to remember this, folks. It's these two tests are designed to test for nerve function. H in heel comes before T in toe, correct? So, H, L5, T, S1. L5 comes before S1. So the L5 nerve root is affected by the L4, L5 disc. The S1 nerve root affected by the L5, S1.